Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Selamat sore, salam sejahtera untuk kita semua. Terima kasih untuk JCCA-PERDATIN JAYA yang telah memfasilitasi webinar kita pada hari ini dengan topik The Past and Future Trends in Icu Sedation. Yang terhormat kepada Bapak Dr. Yohanes WH George, Sp.An KIC, selaku Ketua JCCA-PERDATIN JAYA sekaligus yang akan menjadi panelis kita pada hari ini. Dan yang terhormat para narasumber sekalian, Dr. Rudyanto Sedono, Sp.An KIC, Dr. Vera Irawany, Sp.An KIC, Dr. Haizah Nurdin, Sp.An KIC. Also, our international speakers, good afternoon, Dr. Kerstin, Rohm, and Dr. Luis, and our business partner, Lina Chua and Bern Lepper, serta Bapak Ibu peserta webinar yang berbahagia. Terima kasih. Selanjutnya, acara ini akan dimulai dengan penyampaian sambutan yang akan disampaikan oleh Dr. Yohanes WH George, Sp.An KIC, selaku Ketua JCCA-PERDATIN JAYA. Kepadanya dipersilahkan. Silahkan, Dr. George.
Terima kasih, Mutia. Selamat sore, sejawat-sejawat sekalian. Saya sangat berbahagia pada hari ini kita mendapatkan lagi ilmu baru ya. Firstly, sorry to Kerstin, I have to talk bahasa and Dr. Louis. Kita tahu bahwa tahun 2014 JCCA itu pertama kali mengadakan simpo dengan tema anestesia beyond the OR ya, Dr. Vera ya. Ingat ya dulu.
Iya dok.
Karena saat ini completely hampir anesthetic agent pun beyond the OR.
Yeah.
So if for the anesthesiologist, now you can just move your work from the OR to the ICU with the same agent. Actually, ini sangat menarik sekali ya kalau kita lihat. Makanya terima kasih kepada Pak Amson sebagai Direktur Utama PT Anamed Sejahtera Pharma dan dari rekan dari Singapura, khususnya Dr. Kerstin dan Dr. Louis yang akan sharing their experience using the inhaled anesthetic agent. Saya rasa para audiens ini rata-rata anesthesiologist who well known about the inhaled anesthetic agent, sudah akrab dengan ISO dan sevoflurane, dan saat ini kita tahu bahwa keuntungannya sangat banyak, khususnya eliminasinya karena tidak lewat organ, jadi ke paru ya. Jadi mungkin fast track winning atau early wake up itu lebih benefit lah. Tapi tentu kita harus teknologi, kita minta di sharing tentu yang sudah menggunakan pertama dari Jerman, Dr. Kerstin dan Dr. Vera dari Singapura. Itu yang saya sangat berterima kasih. Mudah-mudahan acara ini berjalan lancar. Nanti ada, kita juga tentu tetap panduan utama dari Dr. Haizah akan menerangkan tentang standar guideline kita, di mana mudah-mudahan ntar lagi inhaled masuk ke dalam ya. Itu aja mungkin dari sambutan dari saya. Terima kasih. Semoga acara berlangsung lancar, dan saya lupa juga berterima kasih kepada Dr. Aldi sebagai pengurus Ketua PERDATIN JAYA yang sudah juga berkontribusi memperlancar acara kita. Demikian, terima kasih. Saya kembalikan kepada Pak Mutia.
Terima kasih Dr. George atas sambutannya. The most influential doctor in JCCA. Terima kasih. Dan kemudian izinkan saya untuk membacakan peraturan yang ada pada webinar ini sebelum kita mulai webinarnya. Ya, semua peserta sudah dalam mode mute suara dan kamera diizinkan aktif. Jadi untuk Bapak Ibu semua yang mau menyalakan kameranya silahkan, dan pastikan suara atau audionya di-mute dulu. Kemudian peserta tidak perlu menginformasikan kembali kehadirannya, data dan absen kehadiran otomatis tercatat pada aplikasi. Poin ketiga adalah sertifikat diberikan kepada peserta yang hadir pada webinar Zoom minimal 75% kehadiran dari seluruh rangkaian acara. Jika memiliki pertanyaan terkait materi presentasi, peserta dapat mengetik pertanyaan melalui kolom Q&A atau dapat juga langsung menanyakan kepada para panelis atau para pembicara melalui moderator kita. Mungkin bisa nanti raise hand terlebih dahulu untuk bisa difasilitasi oleh moderator kita. Kemudian pertanyaan akan dijawab dan dibahas saat sesi diskusi dan tanya jawab setelah pemaparan materi berakhir. Peserta mengisi polling atau survei yang akan ditampilkan di akhir acara webinar. Jika terdapat kendala teknis selama webinar, peserta dapat mengirimkan chat kepada panitia melalui fitur chat. Kemudian terlampir pada layar kita pada hari ini ada kontak JCCA-PERDATIN JAYA. Mungkin bagi Bapak Ibu yang memiliki kendala teknis bisa langsung menghubungi kontak-kontak tersebut. Nah, kemudian berikut untuk mempersingkat waktu, saya mohon izinkan saya perkenalkan moderator kita pada hari ini, Dr. Vera Irawany, Sp.An KIC, anestesiologis dan intensivist di RSUP Fatmawati, dengan riwayat pendidikan Strata 1 Kedokteran Universitas di FKUI, lulus tahun 2021, kemudian spesialis anestesiologi dan terapi intensif di FKUI, lulus tahun 2006, kemudian konsultan intensif care di FKUI lulus tahun 2012 dan saat ini sedang menjalani pendidikan doktor di FKUI. Kepadanya dipersilahkan Dr. Vera untuk mengambil alih acara ini.
Oke, terima kasih Mbak Mutia. Ya, Assalamualaikum warahmatullahi wabarakatuh. Selamat sore, good morning for Dr. Kerstin and good afternoon everybody. Dr. Louis, welcome to Indonesia virtually and we hope that you can come soon to visit Indonesia. I want to speak in Bahasa to say hello to my colleagues. Selamat bergabung teman-teman semua. Jadi sore ini kita akan melakukan menjalankan melalui webinar setelah mungkin kemarin istirahat ya bulan puasa kita mulai aktif lagi berwebinar. Nah, kali ini kita akan membahas tentang sedasi di ICU ya. Jadi ini adalah suatu webinar yang sangat menarik, sesuatu yang baru. Mudah-mudahan nanti teman-teman akan bisa banyak mendapatkan manfaat darinya. Nah, untuk mempersingkat waktu, nanti kita akan segera ke pembicara pertama. Jadi di sini akan ada 3 pembicara. Nanti akan dilanjutkan dengan sesi tanya jawab, di mana terdapat 2 panelis yang sangat tersohor ya. Nanti kita akan perkenalkan di belakang. Oke, without any further ado, so I would like to start the first presentation from Dr. Haizah Nurdin. Dr. Haizah lulusan FK Unhas, juga mengambil spesialis anestesi di Unhas dan beliau menyelesaikan intensive care konsultannya di FKUI. Beliau saat ini adalah kepala ICU ya Dr. Eca. Saya biasa panggil Dr. Eca, kepala ICU di Rumah Sakit Dr. Wahidin Sudirohusodo
Hasanuddin
University Hospital. Oke, kepada Dr. Eca saya persilahkan dengan tema Current Practice Sedation for Critical Patient in ICU. Dr. Eca, the time is yours.
Baik, terima kasih Dr. Vera Irawany atas perkenalannya. Izinkan saya untuk men-share materi saya. Ya, pertama saya mengucapkan terima kasih terlebih dahulu kepada JCCA, kepada Perdatin Jaya, Anamed, Sedana Medical, Intega, yang telah memberikan kesempatan bagi saya untuk membawakan materi mengenai current practice sedation for critical patient in ICU. And I would like to apologize to our international speakers, Dr. Kerstin and Dr. Louis. Allow me to deliver my presentation in Bahasa. Sebagai pendahuluan, untuk outline yang akan saya bawakan pada kesempatan ini adalah ABCDEF, ICU Liberation Concept. Selanjutnya saya akan membahas mengenai analogous sedation concept, kedalaman anestesi, monitoring kedalaman anestesi, mengenai sedation vacation dan daily sedation interruption serta sedative drugs yang pada umumnya saat ini kita gunakan di ICU. Jadi kita tahu bahwa pasien yang dirawat di ICU dengan segala macam alat medis dan penunjang hidup seperti ventilator, kateter, intravenous pump, monitor, mulai dari yang standar hingga advance ini tentu akan menimbulkan imobilisasi dan ketidaknyamanan pada pasien. Selain itu memberikan stres dan nyeri. Karena itu kita membutuhkan sedasi yang adekuat untuk diberikan pada pasien agar pasien lebih comfort, nyaman, menurunkan ansietas, dan memungkinkan pasien menerima tindakan dan perawatan di ICU dengan kooperatif dan tanpa agitasi. Namun di saat yang sama, kita sebagai physician juga harus mempertimbangkan dan secepatnya berusaha untuk mencapai goal perawatan kita, sehingga durasi perawatan di ICU dapat kita minimalkan dengan usaha mencapai target tersebut. Nah, salah satunya dengan implementasi dari ICU Liberation Bundle ini. Jadi ICU Liberation Bundle didefinisikan sebagai filosofi atau praktek menyeluruh yang diarahkan untuk meningkatkan perawatan pasien dengan cara membebaskan atau liberating pasien dari ICU secepatnya untuk menghindari dari nyeri atau meminimalkan nyeri, sedasi berlebihan, delirium, mempercepat pasien liberasi dari mechanical ventilation, imobilisasi dan isolasi, serta memberikan kesempatan kepada pasien untuk lebih sedikit mendapatkan atau tidak mendapatkan gejala pasca perawatan ICU. Nah, dalam studi-studi diperlihatkan bahwa dengan implementasi ICU Liberation Bundle ini dapat menurunkan durasi penggunaan mechanical ventilation di ICU, dapat menurunkan hospital death dalam 7 hari di ICU hingga 68%, dapat menurunkan angka readmisi ICU hingga 46% dan menurunkan angka delirium. Nah, saya kira teman-teman sejawat semua hampir sudah mengimplementasikan ya semua ABCDEF bundle ini dalam rangka bagaimana kita mempercepat liberasi pasien dari ICU. Di mana ABCDEF ini pada kesempatan ini saya akan membahas lebih lanjut mengenai poin C yaitu choice of analgesia and sedation. Namun sebelum saya melangkah mengenai choice of sedation, lebih khususnya beberapa konsep akan saya tampilkan mungkin yang hanya mengingatkan ya, karena ini adalah merefresh kembali konsep-konsep yang telah selama ini kita implementasikan dalam manajemen sedasi pasien-pasien ICU yang akhirnya menjadi pertimbangan utama kita dalam memilih teknik dan obat sedasi yang akan kita gunakan pada pasien. Saya kira kita semua sudah tahu guideline untuk penanganan pain, agitation, sedation, delirium, immobility, and sleep disruption yang kita singkat sebagai PEDIS guideline terakhir pada tahun 2018, di mana untuk penanganan sedasi diantaranya disebutkan di sini menganut sebaiknya menganut protocol based analgo sedation. Jadi konsep ini sebagai suatu hal yang rutin dilaksanakan dalam pemberian sedasi pada pasien. Jadi bisa analgo sedation ini bisa sebagai analgesia first sedation, bisa juga sebagai analgesia based sedation. Ya, jadi pada umumnya kita menggunakan opioid sebagai analgesik sebelum kita menggunakan sedatif. Artinya kita memaksimalkan dulu tata laksana nyeri pasien ini, karena setelah itu baru kita menggunakan sedasinya. Namun ada juga yang menggunakan analgesia based sedation, yaitu kita menggunakan analgesia yang memiliki efek sedasi, dalam hal ini pada umumnya adalah opioid ya, instead of menggunakan sedasi saja. Ini adalah suatu studi yang memperlihatkan bagaimana dengan menggunakan konsep protokol based analgesia, analgo sedation, maka akan menyebabkan durasi mechanical ventilation pada pasien yang mendapatkan analgo sedation itu secara bermakna lebih rendah, loss atau length of stay di ICU-nya itu lebih rendah, dan Richmond Agitation Sedation score-nya ini juga lebih rendah pada pasien yang mendapatkan konsep analgo sedation. Jadi symptom oriented strategies dengan konsep analgo sedation ini pada umumnya untuk analgesia kita menggunakan golongan intravenous opioid, dalam hal ini fentanyl, suventa, dan remi maupun morfin, di mana caution perlu kita perhatikan pada golongan yang terakhir yaitu morfin karena dia adalah memiliki metabolit aktif dan pada pasien-pasien dengan renal impairment kita harus sebaiknya kita hindarkan. Juga dikenal konsep multimodal analgesia dalam tata laksana pasien-pasien di ICU. Selain itu ada konsep e-cash, konsep yang ditawarkan oleh Vincent dan Shehabi, yaitu early implementation comfort pada pasien yang dirawat di ICU, memastikan analgesia telah tertata laksanai dengan adekuat, lantas kita menggunakan minimal sedatif, dan memiliki target serta lebih fokus kepada patient center atau human person dengan family center. Artinya kita melibatkan family engagement atau keterlibatan family juga di dalam perawatan. Nah, ini yang ditawarkan disebutkan oleh Vincent dan Shehabi, yaitu pada pasien yang early after ICU admission kita memastikan apakah pasien comfort atau tidak, dan kita menata laksanai dengan cara bersifat person center care dengan terlebih dahulu memberikan tata laksana analgesia ya kalau memang pasien memiliki suatu simptom atau nyeri, dan selanjutnya kita memastikan pasien dalam keadaan comfort, tidak distres, tidak merasa cemas dengan menambahkan sedasi dengan sedasi yang minimal, sehingga dengan demikian sedasi minimal dan targeted ini bisa kita capai dan kita dapat menghindari unjustified sedation yang terlalu dalam. Jadi sedasi yang dalam dengan melakukan titrasi sedasi dengan goal patient comfort ya. Namun pada beberapa populasi, pada beberapa kondisi sedasi ringan atau light sedation ini tidak bisa kita implementasikan. Sedasi dalam atau moderate itu memang relevan pada beberapa situasi, termasuk seperti yang di bawah ini nanti akan saya sebutkan lebih jauh lagi. Untuk kedalaman sedasi juga pada PEDIS Guideline 2018 disebutkan bahwa lebih direkomendasikan untuk pada pasien sakit kritis dengan critically ill dengan mechanical ventilation disarankan rekomendasinya conditional strength. Untuk strength-nya conditional dan quality of evidence-nya low, direkomendasikan untuk light sedation dibanding dengan deep sedation. Di mana belum ada definisi yang universal mengenai light sedation. Namun dalam PAD Guidelines 2013 oleh Bar dan kawan-kawan, mereka merujuk pada CRES dan kawan-kawan bahwa light sedation itu berdasarkan objektif scale measurement dengan menggunakan REST scale itu skor -2 sampai +1 dan didapatkan eye opening sekurang-kurangnya 10 menit. Dan kita tahu bahwa light sedation ini memang direkomendasikan karena dia berasosiasi menurunkan waktu untuk ekstubasi sejak pertama pasien diintubasi dan menurunkan jumlah atau kejadian tracheostomi pada pasien-pasien yang dirawat di ICU dengan mechanical ventilation, dan ini tidak berhubungan dengan penurunan insiden delirium, post-traumatic stress disorder, depresi maupun self-extubation. Jadi untuk light sedation di ICU tadi saya sudah sampaikan, meskipun belum universal definisinya, tapi masih melihat berdasarkan yang disebutkan tadi oleh CRES bahwa berada di -2 sampai +1. Nah, tadi pada beberapa kasus deep sedation memang harus kita lakukan dan relevan pada pasien-pasien tertentu, misalnya pada pasien dengan severe respiratory failure dengan disinkroni ventilator patient, dan adanya pencegahan awareness misalnya pada pasien-pasien yang mendapatkan neuromuscular blocking agent, dan pada pasien-pasien setelah menjalani operasi yang membutuhkan immobilization yang strict, misalnya pada pasien yang menjalani operasi tulang belakang servikal, misalnya seperti itu. Dan beberapa kasus brain injury dengan peningkatan tekanan intrakranial. Namun kita tahu bahwa deep sedation memiliki problem Di antaranya yaitu loss human contact, sehingga pasien itu mungkin akan bisa mengakibatkan, inilah nanti yang akan mengakibatkan prolong ICU dan hospital stay, bisa mengindus terjadinya delirium, bisa mengakibatkan microaspiration, dan beberapa efek-efek lain yang sangat kita hindari dalam perawatan pasien di ICU. Selanjutnya untuk monitoring kedalaman sedasi bisa kita menggunakan di ICU, kita bisa menggunakan subjective monitoring dan objective monitoring. Untuk subjektif yang selama ini reliable dan paling sering kita gunakan juga disebutkan pada PEDIS Guideline 2018 ya, yang ini adalah RASS atau Richmond Agitation Sedation Scale dan Ricker Sedation Agitation Scale. Jadi dua ini meskipun terdapat juga beberapa subjektif monitoring yang lain. Namun di kita sendiri dalam current practice kita yang paling sering kita gunakan adalah RASS dan SAS. Untuk objektif monitoring yaitu di 2018 disebutkan, PEDIS 2018 disebutkan mengenai kuantitatif EEG. Dalam hal ini untuk memonitoring fungsi dari primary target anesthetic drug, dalam hal ini di brain, di mana dengan menggunakan objective monitoring kita bisa memberikan sedative dose in ICU yang lebih bersifat personalized. Di mana di PEDIS guideline disebutkan mengenai objective sedative monitoring, meskipun masih ungraded statement, dikatakan bahwa BIS monitoring ini tampaknya cocok dalam titrasi sedatif pada pasien yang mendapatkan deep sedation dan neuromuscular blockade di ICU. Dan pada pasien-pasien yang agak sulit kita lakukan penilaian secara subjektif untuk sedation scale-nya. Untuk sedation vacation, nah ini merupakan suatu konsep juga, suatu metode yang kita gunakan untuk meminimalkan oversedation pada pasien yang kita rawat di ICU, yaitu kita kenal juga sebagai daily sedation interruption. Dan ini masuk di dalam poin ABCDEF bundle, masuk di dalam B, yaitu SAT atau Spontaneous Awakening Trial, di mana didefinisikan DSI atau Spontaneous Awakening Trial merupakan usaha kita untuk membangunkan menghentikan sedasi ya setiap hari pada suatu periode dengan cara menghentikan sedasi dan melihat apakah pasien bangun dan alert yang didefinisikan sebagai pasien respon terhadap suara atau mengikuti komen, perintah, dan dengan SAS atau Sedation Agitation Scale 4-7 atau RASS -1 hingga +1. Di mana dengan menggunakan daily sedation interruption ini kita berusaha untuk merupakan usaha kita untuk mencegah oversedation, di mana pasien-pasien yang menerima infus opioid dan atau sedatif dengan melakukan DSI ini studi memperlihatkan penurunan durasi mechanical ventilation, ya tentu karena kita begitu mengetahui respon pasien, nah kita bisa berusaha untuk reevaluasi kembali kebutuhan sedasi dan menyesuaikan dengan kebutuhan pasien sesuai dengan target yang kita inginkan, dan sebagai usaha kita untuk menurunkan akumulasi medikasi atau dalam hal ini obat sedasi dan opioid yang digunakan pasien. Serta kita berusaha transisi, bisa kita transisi pola atau metode pemberian obat kita sesuai kebutuhan, jadi bukan continue lagi. Nah ini adalah tapi beberapa kekhawatiran ketika dilakukan daily sedation interruption itu adalah pasien akan menjadi mengalami hiperkatekolamin release ya, sehingga berdampak buruk pada pasien. Namun dalam suatu studi pada kelompok pasien dengan resiko coronary artery disease, ternyata didapatkan memang ada terjadi peningkatan. Jadi pasien ini dilakukan daily sedation interruption dan dipasang continuous monitor, Holter monitor dengan melihat ST segment analysis. Dan ternyata memang didapatkan heart rate, MAP, rate pressure product itu pada saat dilakukan off sedation meningkat secara bermakna dibanding baseline. Juga peningkatan epinefrin, norepinefrin, dopamin juga meningkat secara bermakna pada saat dilakukan off sedation. Tentu populasi ini adalah pasien yang tidak mendapatkan support. Namun ternyata ketika dievaluasi dari Holter monitor untuk ST segmen analisisnya, ternyata ini tidak DSI ini tidak berasosiasi dengan peningkatan kejadian miokardial iskemia. Sehingga ketika memang pasien sudah memenuhi kriteria untuk atau boleh kita lakukan daily sedation interruption, bisa kita implementasikan. Nah, selanjutnya yang terakhir adalah mengenai sedative drugs yang kita gunakan di ICU. Ada beberapa macam yang biasa kita gunakan, pada umumnya adalah golongan intravena saat ini, mostly, ya, di mana saya menggarisbawahi ini ada 3 yang paling sering kita gunakan. Yang pertama golongan benzodiazepin, midazolam, propofol, dan dexmedetomidine. Di mana untuk golongan midazolam kita tahu dia memiliki aktif metabolit sehingga dia bisa agak lama untuk kita menunggu pasien awake pada saat setelah kita hentikan infusnya. Dan untuk propofol sendiri beberapa adverse effect yang bisa kita dapatkan yaitu hipertrigliseridemia, pankreatitis, allergic reaction, khususnya jika kita menggunakan pada waktu yang lama dapat dan dosis yang besar dapat menimbulkan PRIS atau propofol related infusion syndrome, dan waktu emergency yang lebih lama jika kita menggunakannya lebih lama pula dalam praktek sedasi kita. Untuk dexmedetomidine saya kira sudah sering kita dapatkan juga pasien mengalami bradikardia dan hipotensi, meskipun dengan dexmedetomidine ini memberikan analgesia, ansiolitik, dan relaksasi yang lebih bagus dibanding yang lain-lainnya, serta light anesthesia yang bisa dicapai dengan dexmedetomidine. Jadi dexmedetomidine tidak menimbulkan deep sedation, namun hati-hati dia bisa mengakibatkan resiko untuk withdrawal. Untuk midazolam, semua golongan benzodiazepin menyebabkan resiko delirium dan resiko untuk terjadinya withdrawal. Selain itu, beberapa agen sedatif lain, diantaranya seperti hal golongan benzodiazepin yang lain, yaitu lorazepam, namun kita belum memiliki sediaan intravena di Indonesia. Nah, lorazepam juga sama dengan midazolam menyebabkan delirium dan menyebabkan withdrawal. Untuk isofluran dan inhaled sevofluran tidak menyebabkan delirium dan withdrawal, dapat digunakan untuk menginjus sedasi yang dalam, tidak ada akumulasi pada hepatik dan renal failure, dan namun perlu kita anamnesis lebih jauh mengenai resiko malignan hipertermia barangkali kalau kita hindarkan pada pasien-pasien yang beresiko untuk itu. Sehingga sebagai choice of sedation, maka kita berdasarkan dari kedalaman sedasi yang kita inginkan, apakah kita membutuhkan efek amnestik dan kemudahan dari titrasi dari obat-obat yang kita gunakan. Dan yang paling penting lagi di tempat kita juga biaya ini merupakan faktor yang paling penting juga dalam memilih sedative agent. Sehingga untuk memperoleh sedative agent yang bagus, kita membutuhkan sedative agent yang dapat memberikan comfort dan safety pada pasien-pasien yang kita rawat di ICU. Beberapa side effect sedative anesthesia yang lain, mungkin ketamin. Ketamin ini juga beberapa mungkin pernah menggunakan ketamin, low dose ketamin, untuk tata laksana sedasi di ICU, tapi resiko dapat mengakibatkan hipertensi, sekresi, dan disforia. Untuk eliminasi tadi, beberapa obat-obat memiliki aktif metabolit seperti midazolam, memiliki aktif metabolit, dan eliminasi kebanyakan obat-obat intravena untuk sedative agent itu di metabolisme di hepar dan dieliminasi di renal, sehingga kita perlu hati-hati pada pasien-pasien yang di ICU yang sudah mulai mengalami masalah atau gangguan pada hepar dan renal. Untuk decrement time, yaitu waktu untuk menurun konsentrasinya di dalam plasma setelah dihentikan infuse continue-nya, untuk 80% decrement time ini masih paling lama diduduki oleh midazolam ya. Jadi midazolam setelah kita hentikan, khususnya jika penggunaannya lebih lama, itu decrement time 80%-nya bisa sampai 12 jam hingga beberapa hari. Dan sedikit lebih rendah dibanding untuk propofol menyusul kemudian dexmedetomidin dalam hitungan jam, dan untuk isofluran dan sevofluran itu dalam hitungan menit ya setelah kita hentikan. Sehingga untuk penggunaan sedation agent atau agen-agen sedasi intravena di ICU itu kita perlu, tadi saya sudah sampaikan, di mana beberapa pasien ICU biasanya memiliki atau berisiko untuk mengalami gangguan hepatik dan renal function, sehingga kita perlu hati-hati pada obat-obat intravena yang mengalami eliminasi dan bersifat organ dependent terhadap hepatik dan renal, karena dapat mengakibatkan perpanjangan eliminasi, resiko akumulasi dan oversedation, serta waktu untuk wake up lebih lama pada pasien dan memanjang waktu pulih sadarnya dari sedasi. Dan tentu ini akan menambah loss di ICU. Sehingga idealnya bahwa dalam memilih sedatif pada pasien yang dirawat di ICU, beberapa poin-poin ini setidaknya terpenuhi ya. Sebaiknya terpenuhi sebagian besar, atau kalau bisa semuanya terpenuhi ya, bahwa agen sedatif itu bersifat sedatif, analgesik, dan ansiolitik. Dia rapid onset dan offset actionnya juga rapid, dan dia dose response relationship itu bisa kita prediksi, side efek sampingnya lebih rendah, dan dia sebaiknya tidak bersifat organ independen untuk eliminasinya, khususnya pada pasien-pasien sakit kritis yang sudah mengalami gangguan hepar dan renal. Idealnya juga tidak memiliki aktif metabolit dan tidak memiliki akumulasi, serta tidak memiliki reaksi yang berbahaya dengan obat-obat yang lain, atau memiliki minimal drug interaction. Sebagai kesimpulan bahwa ICU liberation bundle yang kita implementasi di ICU ini termasuk di dalamnya dalam manajemen sedasi. Ini membantu dalam kita memberikan tata laksana layanan pasien yang bersifat komprehensif dan mengoptimalisasi seluruh resource yang ada, sehingga kita dapat menghasilkan perawatan yang lebih interaktif terhadap pasien-pasien di ICU. Jadi kita dapat mengerti apa keinginan pasien, bebas dari stres. Untuk analogo sedation konsep merupakan konsep yang telah kita implementasikan sejak dahulu dan dalam tata laksana sedasi, di mana kita menggunakan pain sebelum kita menggunakan agen sedasi pada pasien sakit kritis, dan ini akan meminimalkan medikasi sedasi yang kita gunakan di ICU. Selanjutnya adalah penggunaan sedatif yang appropriate, yang sesuai, dapat memfasilitasi dalam pelayanan pasien kita, yang mengakibatkan pelayanan yang bersifat memberikan kenyamanan pada pasien atau patient comfort, dan bersifat patient safety. Kita tahu bahwa pasien sakit kritis di ICU kadang memiliki atau seringnya memiliki gangguan pada organ, termasuk di dalamnya adalah hepatic and renal function, di mana konsekuensinya yaitu efek metabolisme obat itu dapat terpengaruh akibat gangguan hepatic dan renal function tersebut. Maka kita harus berhati-hati dalam pemilihan agen intravenous sedasi pada pasien-pasien dengan masalah seperti itu. Saya kira cukup dari saya, semoga bermanfaat. Terima kasih Dr. Vera, saya kembalikan ke Dr. Vera.
Oke, terima kasih Dr. Echa, paparannya sangat jelas, dan kembali kita mereview lagi bagaimana kita melakukan manajemen sedasi dan pemberian analgetik di ICU ya. Nah, tadi sudah kita lihat apa obstacle-nya, apa masalah yang selama ini kita alami. Nah, adakah alternatif lain yang bisa kita lakukan? Nah, kita akan masuk ke pembicara kedua ya. Nanti tahan dulu pertanyaan untuk Dr. Echa, kita akan bahas di belakang ya. Kita akan masuk ke sesi kedua, yaitu Advanced Sedation in ICU yang akan dibawakan oleh Dr. Kerstin Rohm. Halo Dr. Kerstin. Oke, beliau saat ini di Jerman. Beliau adalah seorang anesthesiologist intensivist. Beliau sekarang memegang ICU ya. Sebentar saya lupa. Nah, Head Physician of ICU Department of Anesthesiology and Intensive Care St. Mary and Anna Hospital di Ludwigshafen, Jerman. Oke, Dr. Kerstin, this is your time. Please.
Here. Okay, let me first share my screen.
Okay.
So by now you might see my slides. Is that right?
Yes. Clear.
Okay, thank you very much to be part in this webinar, and I'm happy to be here and to speak about advanced sedation in the ICU and actually inhaled sedation in the ICU. These are my conflicts of interest. And that you have a good idea where I am sitting now. I just brought up this world map to know here you find Indonesia, and I've seen a lot of spectators today in this webinar. And this is why I'm actually sitting here. I'm head of an ICU with 16 beds, 8 ventilator beds, and intensive and intermediate care. And it's very much in the southwest part of Germany, near the French frontier. And we are one part industrial. We have this big headquarter, the BASF, the chemical company in our town, Ludwigshafen. And we are a region with a lot of agriculture and wine production. And we have a lot of white wine, the Riesling, that is known all over the world. So this is where I am sitting now and presenting and try to involve you in inhaled sedation in the ICU. How was it in the very beginning? Actually, I started with volatile anesthetics in the ICU 16 years ago. I was addressed at the EasyChem Congress, the big intensive care congress in Brussels, where somebody told me about using volatile anesthetics that I have been using as an anesthesiologist and intensivist for many, many years before, to use it now in the ICU, just half a meg. So I was very interested because I was familiar with volatile anesthetics. And from Dr. Haizah, you have heard a lot about ideal sedatives and the strategies we have to use in the ICU. At the moment, we intubate a patient and we have to liberate him later in the ICU. And if we are talking about the choice of sedatives, it becomes very clear as an anesthesiologist to use volatile anesthetics in the ICU. So which are the agents actually that we are using in the ICU? The volatile anesthetics are not new. We know this famous picture here from 1846 with the first ether narcosis in Boston, USA, but then it needed more than 100 years to develop agents that were not corrosive, not explosive, that can be used in patients without any harm. So nowadays we use halogenated ethers, and the most modern ones are isoflurane, sevoflurane, and desflurane. And these 3 agents we use a lot as anesthesiologists in the OR. In Germany, it's a little bit more sevoflurane than desflurane. Isoflurane is something we sometimes use for long operations. They had been clinically introduced in the 80s and 90s, so we know about adverse events and side effects of these drugs very well. Only desflurane is a little bit a different substance we use in the OR, where we have to use a special vaporizer technique to lower the temperature, because the boiling point is quite low, quite high already. At the moment we are in room temperature, and the MAC value, which is the potency of the agent, is quite low, so just 1/6 of isoflurane. So this is a substance we usually don't use in the ICU, and there's only one technique we can use it nowadays. And usually if you use desflurane, for example, you need around 6 bottles a day. So that is not cost effective at all. So I will mostly stick to isoflurane and sevoflurane and tell you which agents we use in the ICU. First of all, to get you a little bit more familiar, for those who are not anesthesiologists and not familiar with volatile anesthetics, you have to know about the MAC value, the minimal alveolar concentration. That is the mean alveolar and tidal concentration of a volatile anesthetic that prevents skeletal muscle movement in response to a surgical incision in 50% of the test patients or populations. So that sounds cruel at the first moment, but it was actually invented in the 60s, where they used a lot of volatile anesthetics alone to perform operation. But the MAC value still exists because it gives you a very good comparison of the different volatile anesthetics. And you can see here on the left side, the highest potency with halothane and isoflurane on the one side, and desflurane and nitrous oxide on the other side. So isoflurane is the substance we use the most of the time in the ICU nowadays in Germany, and it has a much higher potency than, for example, sevoflurane. With the MAC value, we know that with patient's age, it decreases. For example, the older patients, they need less volume percent of volatile anesthetics. The small newborns, they really take a lot of volume percent if you perform anesthesia in those little children. And the MAC value decreases as well with body temperature, pregnancy, anemia, and the administration of a second gas, for example. It's not dependent on time. It means if you use, for example, volatile anesthetics for 2 days or 1 week or 2 weeks, the MAC value doesn't change at all, and there's no accumulation. And we have already heard from Dr. Haizah a lot about the pharmacokinetics and dynamics of IV and inhaled sedation. And I just want to highlight a little bit more how different the strategy is to use inhaled sedation. Usually we use IV sedatives, so they are injected intravenously via a central line or a line here at the hand. You can see we have an absorption of our substance, for example, propofol, midazolam, or dexmedetomidine. The substance is distributed and the site of action is actually the brain. And then when we stop our agent, as the former speaker said, we are highly dependent on hepatic metabolism and on elimination. That is different in volatile anesthetics. The administration goes via the lung. It's a different system of administration of drugs. It's inhale. It's depending on inspiratory fraction. If you use a vaporizer, that is usually the fresh gas flow and concentration at the vaporizer, which is not part in the ICU. But it highly depends on alveolar ventilation, which is respiratory rate and mechanical ventilation. And the drugs are taken up from alveolar to the blood, and they depend on cardiac output, of course, on the blood flow in the lung, the perfusion, and the blood solubility of the volatile agent itself. The site of action, again, is the brain by an interaction of mainly GABA receptors. At the moment you stop the drug, it's not metabolized, it's not renally excreted, but it's exhaled. So it's depending on this alveolar ventilation, on the mechanical ventilation of our patient to get rid of the drug. And this is something that we as anesthesiologists are very familiar. We stop the sevoflurane vaporizer in the OR, and we're going to be sure that within 5 to 10 minutes, the patient is going to be woken up and we can extubate him. So that is really the difference. And you have seen this slide before. I just want to highlight once again the volatile anesthetics on the left side and the IV sedatives on the right side. The isoflurane is only metabolized by 0.2%. It produces trifluoroacetic acid and fluorides, but the fluorides level that have been discussed in the 70s to produce a renal dysfunction are very, very low, and they usually don't come over a margin of 50 micromole per liter. With sevoflurane, we have a little bit higher metabolization, up to 5%, and the fluorides level are higher. So in Germany, we have come to understand that fluoride level, we're not exactly sure if it really produces harm to the patient. So we have some cases, 4 to 5 cases, talking about a diabetes insipidus related to fluorides. So this is why we restrict the sevoflurane administration for some days, like 3-4 days, and change to isoflurane, or we start isoflurane directly. Both drugs are exhaled from the lungs, whereas propofol, dexmedetomidine, and midazolam have to be excreted. And you all know this phenomena of midazolam with the accumulation and the active metabolite, that you have a critically ill patient, he's intubated like 2 weeks, and then you're waiting like 4 days, 5 days to at least have a RAS score -2 or -1 to interact with the patient. That is really different when you use inhaled sedation. So next thing is, where do we apply the volatile anesthetics and when do we start inhaled sedation in ICU? Before the millennium, there were some enthusiastic anesthesiologists. They put a vaporizer that you can see here on the left side in the inspiratory limb of their ICU ventilator. The problem is an ICU ventilator is different to an anesthesia machine. And we don't have a closed circuit where we have a recirculation. We have a half open system, and from the exhaust, we have a lot of gas coming out in the environmental air of our patients' rooms. So there had to be an invention first to safely apply volatile anesthetics, and with economic application of volatiles. That is comparable to a fresh gas flow of 1.5 liters per minute. And this was around 2000 with the anesthetic conserving device. And in Germany, we had the launch of Anaconda in 2005. I got to know about Anaconda in 2006 and started with inhaled sedation. Last year, we got the launch of Sedaconda because it used to be an off-label use. We were familiar with using volatile anesthetics in the OR, but bringing it to the intensive care unit meant that there is an off-label use because we're not in the OR and a different system. So by now, we are on an on-label use as well in Germany. Just to get you familiar with the anesthetic conserving device, this is a cut through the filter. On this side, you have the Y piece and the tubes coming from the ventilator. On this side, you have the endotracheal tube. What you can see here, we have some kind of a vaporizer here where connected to line and a syringe pump, we deliver isoflurane and sevoflurane to the patient. The patient inhales the drug during inspiration. In expiration, the volatile anesthetics come back and they are stored here in these carbon fibers, and they are reflected in 90% in the next inspiration to the patient. Included with this filter with the carbon fibers, we have an HME filter, which is antibacterial and antiviral, and you can easily use it in COVID-19 as well. It's very protective. So to get you a good idea how it looks like in real life, so that is woman intubated, she's intubated with via the endotracheal tube here, you can see it here. Then we have a tube elongation going to the HME filter. The anaconda filter is exactly where you can find the HME filter. You just take the HME filter out and you plug this anaconda reflecting filter in. And then here we have two-in-one host. Usually you have the white piece here, and it's connected to the ventilator. We have from the exhaust of the ventilator a scavenging system, because we know that 10% of the volatile anesthetics are going out from the ICU ventilator, and they are distributed in the air of the patient's room. Although you might have a high exchange rate, we want to avoid by any means environmental pollution. So we have this passive scavenging system hooked to the exhaust. You can see here as well a closed suctioning system. This is to avoid environmental pollution for the nurses, the healthcare staff, and we use here nebulization in this patient to get the secretion off. When do we actually consider volatile anesthetics in the ICU? We are in Germany quite familiar with this inhaled sedation strategy. Since 2010, inhaled sedation is in our recommendation of analgesia, sedation, and delirium management in the ICU. And this is the latest update here. And it says all patients that are invasively ventilated can be sedated with a sedation goal of -2 or less. And if you have a look here at the right side, this is an algorithm in German. You can see we always start like, if there is any indication for sedation, then we have an aim. An aim can be, for example, the ROS score, a -1, -2, -3, whatever the patient needs. And then the first choice, we have propofol and analgesia. And the only alternative we have nowadays in the recommendations is inhalative sedation and analgesia. Midazolam is no longer recommended. We only give it in a bolus form. In my ICU, I have this SOP. We always have a look at the patients that are coming into the ICU, and then we judge them if it's just a short-term sedation, and we just keep them with propofol, wean them, and extubate them. If they cannot be extubated within the first night, or we already have a patient where we know he needs to have a second look operation, we're going to have a really severe ARDS or multi-track dysfunction, then we consider that it's going to be a longer sedation, more than 24 hours. And then we start with analgesia first. Sulfentanyl is the drug of choice in most hospitals in Germany. And then we decide on volatile anesthetics or propofol. Propofol is restricted in Germany for 7 days and only in dosages under 4 milligram per kilogram per hour for the PRES syndrome. So most of our patients, they go to isoflurane or sevoflurane. Isoflurane, we usually start 3 to 6 ml per hour, sevoflurane 5 to 10 ml per hour, and only 3 days because of the fluorides. Other options are only for palliative situation or for co-sedatives if we have to use it in our patients. Who might profit from inhaled sedation? And this is something I want to go through different studies that you get to know a good hint where patients have been evaluated. The so far largest studies is coming from Germany and Slovenia. We randomized 301 patients and compared isoflurane to propofol. It was a sedation and ventilation more than 48 hours. And you can see here on the graph the awakening of the patients. The awakening was not different. And this is something we, of course, expected. Within 24 hours, we don't have a really big difference between propofol and isoflurane. So we have the same awakening here on the first day, but already on the second day, we see that there is a difference between propofol and isoflurane, and it was more predictable for the isoflurane group to have an awakening trial, a daily interruption of sedation, and a quicker awakening. And as a side effect, it was seen that spontaneous breathing was more frequent already on day one. This is something we have learned over time, that we can wean, not really wean, but we can have a spontaneous breathing pattern, pressure support ventilation in most of our patients very, very early, even in prone positioning, for example. And something else was seen in the study, and this is something we have learned over the last 15 years, that we can spare opioids. Opioids, we often have problems with the gut motility, especially for operative abdominal operation. They all suffer from atonia from the gut, and this is how we can spare analgesia a lot. By the same BPS gain, here, the behavioral pain scale, we have a lower usage of morphine. This is, it's actually sulfentanyl, but it was classified as morphine equivalent dosages. Less use of opiates compared to the propofol group. For me, it's more important to have information about sedation for a long term. And this is one study coming from the Karolinska Institute in Stockholm, where they investigated 40 patients, 20 getting isoflurane and 20 getting midazolam. And they were sedated for more than 4 days for pneumonia. You can see here on the left side, the time to follow verbal command, and on the right side, the time to extubation. And you see this huge difference between 10 minutes at a mean for isoflurane to wake up, follow commands, and being extubated, like in the OR, compared to using midazolam that was higher than 100 minutes. So this, for me, as a critically ill patient, that makes the difference in the long term. And then there have been other investigations. Here we have a study from Kranich, from Charité Berlin in Germany. They had a look at the patients coming from an out-hospital cardiac arrest, being admitted to the ICU and treated with a targeted temperature management, a TTM strategy. And they had a look at their ventilation time and their length of stay in the ICU. Although this was retrospectively, we have to say there is a great difference, if you have a look here at the graph, between volatile anesthetics and intravenous sedatives. That is a difference of 4 days, not only for ventilation duration, but also for the discharge from the ICU. So it seems that we're really doing good in having different strategy for special patient groups to be used in the ICU. And there had been a post-hoc analysis of the SEDA-CONDA study. The study I presented first, the randomized controlled trial of more than 300 patients. And although the time period of this initially study was only 48 hours, of course, there were patients that were longer sedated and critically ill. And these patients have been categorized afterwards to only haven't received isoflurane, and others who only received propofol for more than 12-14 days. You can see here, this post-hoc analysis revealed that we have more ICU-free days when using isoflurane compared to propofol. And this is what makes the difference in Germany, because we have a healthcare system based on a DRG, meaning that we don't have to pay for the sedation strategy in the drug or the anaconda itself, but it comes all together in a complex intensive care therapy, and the payment per day is around 2,000 euros. So if we can spare 1 day, it means for the healthcare system in Germany that we're sparing 2,000 euros per patient. So if I can see here a difference of 4 days, that is a lot of money. And this is how we calculate the cost for sedation in Germany. For ventilator-free days, that was a difference of 2 days, but did not reach significance. There was another study looking at mortality retrospectively in the University of Bochum, and they had a look at their patients that were ventilated more than 4 days, and they divided them to isoflurane and IV sedation, that is propofol, midazolam, and they saw that hospital discharge was 63% when using isoflurane and 40% when using propofol, midazolam. And when they had a look at the mortality, not only at 30 days, but after 1 year, they investigated their patients after 365 days. They saw that still they had a difference in mortality that is 20%. So it seems that with volatile anesthetics in the ICU, we can really change the outcome of the patient. And then I'm often asked if I can use volatile anesthetics and the strategy of inhaled sedation in ARDS and in COVID-19 patient. And the short answer is yes. But the thing is, I especially use for all my patients that had any compromised lung function, if it's pneumonia, ARDS, if it's sepsis, if it's any trauma patient, thoracic surgery, I usually use inhaled sedation. And what has been seen here is that they have a better oxygenation. This is a study from Jerman from France, Clermont-Ferrand, and he had a look at ARDS patients in a pilot study. This is only 50 patients for 48 hours of sedation. And the primary endpoint was oxygenation index. And if you have a look at the graph here on the left side, you can see it needs 1 day that it starts to have a difference of oxygenation for the patient. This is something we often see, that it needs like 1 to 2 days to open up the lung, to really have bronchodilation effects and have better oxygenation. And then with sevoflurane, they used here, they had a better oxygenation over the next days compared to midazolam. And they as well investigated as a second endpoint the cytokines levels, and they used this S-range. What is S-range? S-range is some kind of a marker in alveolar epithelial cells, and that is excreted at the moment you have apoptosis and damage. And they saw not only in plasma, but also in alveolar lavage, they saw that the S-range is much, much lower when using sevoflurane compared to midazolam. And we have used with the COVID-19 pandemic a lot of volatile anesthetics in Germany and in Europe especially, because we were not only lacking propofol, but we had the idea that we can have a deep sedation, have the patient freeze themselves and put them on prone positioning easily. And here you have one of the first investigations with 20 patients, isoflurane compared to propofol sedation, and they placed the anesthetic conserving device on a normal white piece where you have the HME filter, and they saw that the RAS score was a little bit lower when using isoflurane compared to propofol. But what they saw, and this was our experience as well, we usually don't use neural muscle blockage agents in our patients. We only use them as a bolus if we really have to prone them and they are quite obese. So what the colleagues saw here, that they had a lot of less use of muscle relaxants. They didn't have to use so many co-sedatives, the polypharmacy use. This means that you had to add ketamine or clonidine or dexmedetomidine to your patient, or even midazolam, when using volatile anesthetics, and opioid use was much less. They had several patients on ECMO therapy, and they experienced, at the moment they go to a baby lung concept and ECMO, they put half the rate of the syringe pump usually used in their patients, that is 7 ml per hour. As a mean, they had 3.5 ml, so just half of the normal dosage you would use in inhaled sedation. And there are other concepts. When you have, for example, lower tidal volumes under 200, and you want to use it in ECMO therapy, or you want to use it, for example, in children, then you can use it in a different manner. You can have a different setup with the anesthetic conserving device. The alternative setup here in the inspiratory limb of your ventilator circuit, not here at the white piece, but inspiratory, you can use a heated humidifier. Of course, you're going to have higher dosages because you will have a loss from the exhaust of the ventilator, but this works very well. You see this investigation from Traselli from Monza, Italy. They used it in veno-venous ECMO patients, and they usually had a mean duration of isoflurane of 7 days, 1 week, but they had several up to more than 1 month. And this is my experience as well. You can use it as long as you need it in your patient. That is not really an accumulation. Of course, critically ill patients wake up differently. They don't wake up in 10 minutes like in the OR, because they usually have suffered sepsis and encephalitis and everything. But it's quite common that they wake up quickly within 1-2 hours, and then you wean them, for example, and if they really have a sympathetic high tonus, then you add a little bit of clonidine, and then you make them breathe and extubate him, or if they are tracheotomized, you start to wean them. So here I'm already at the end of my talk. And let me just summarize what I was talking about. Already from Haizah, you learned why it would be reasonable to use inhaled sedation in the ICU, considering pharmacokinetics. I tried to tell you where to put the anesthetic conserving device and how the technical issues are. And I think Dr. Lewis is going to highlight some topics here, some more topics. The patient groups, it is that you can use volatile anesthetic in any patient if the patient is not related to MH, malignant hypothermia, or has a bronchopleural fistula and a loss of gas environmentally. But some of the patients, they really seem to profit in ARDS after resuscitation, long-term sedation. All these patients might really profit from inhaled sedation. When to start is something that you have to decide on your ICU. We usually start within 1 day, 24 hours. Which agent should you use? That depends a little bit of what you have in your country. In Germany, we have a lot of isoflurane together with the anesthetic conserving device. In some areas, they still use sevoflurane, and I have used sevoflurane in the very beginning just to get some knowledge. Nowadays, I use isoflurane, but I know that around other countries, they only have sevoflurane, and isoflurane is not on the market. So this is possible for your patient, no problem. What you will need is some kind of education and training. And this is why we are here today in this webinar, that you get to know how it works, what you might need in your ICU, and how this concept can be attractive to your intensive care as well. And then I thank you very much for your invitation, and I hand back to Dr. Vera. Thank you.
Thank you very much, Dr. Kerstin. It's so clear, and I think our audience will trigger question from your explanation. It's very clear about the 6W about inhaled sedation in ICU, and then the evidence you also presented very well and clear. Now, who has running the inhaled sedation in ICU in Asia? Singapore have also implemented the sedation inhalation in ICU, and I would like to introduce Dr. Luis. He will share his experience with volatile anesthetic agent for sedation in ICU. We know that Luis is our neighborhood. He worked as anesthesiologist and also intensivist in Changi General Hospital. Without any further, please, Dr. Luis, for sharing your experience in this field. The time is yours, Dr. Luis.
Hi, thank you everyone for the kind invite to this talk. Okay, can everyone see my screen?
Yes, clear.
Okay, so I think Dr. Kerstin have highlighted all the academic as well as all the evidence with regards to inhaled anesthesia in the ICU. So it's not something new, and it's not something that is groundbreaking over the years, but it's something that we have just started using in the local setting. So maybe some disclosure before I go on to my deck of slides. I have been invited for some of these speaker forums by various pharmaceutical companies. Currently, it's Intiga that's inviting me for the talk, and I'm happy to share some of our experience here. So the content that I will go through is the rationale in engaging and using the Anaconda system for our healthcare, for our hospital in Singapore this time round, how we set it up, our first experience until now, as well as some conclusion. So I won't touch much on evidence and all this academic stuff. I'll go directly into very practical stuff, which I think will be something that is unique to us at this point of time. So why inhalational sedation in ICU? If I may summarize Dr. Kerstin's slides so far, like I mentioned, it's not something new. It's been around for a long time. We have been using it in and out, off and on in ICUs in the Western countries for a long time, but it's never ever picked up in the Asia setting because we had never felt a need to, and because our markets are small in a certain sense, and that's why it's never come by us. Inhalationist has also been used in anesthesia for more than hundreds of years, from the back in the days when ITER was around. And why is it picking up now? The COVID pandemic exposed significant weakness in our pharmaceutical support as well as logistics. And as what Kerstin mentioned, there were huge issues with supply chain, especially in the early pandemic. We heard major issues in many hospitals in Europe, running out of medicine, running out of drugs, having to share medications, having to share ventilators. And this was the main issue that prompted us on this journey to look for other types of sedation. In Singapore, although we are relatively spared from the crisis, but we are acutely aware how vulnerable we are. We hardly produce any of the drugs locally, and we are very reliant on every other countries all around us and from Europe producing the drugs and then sending it to us. And when everyone is tight, we need some alternative source that's not so traditional and can last longer. The wider, the more diverse the drug source, the better we can survive a crisis. And thus, we embark on this journey. So the Anaconda system, to summarize what Kerstin has really said so far, other than all the good stuff, is to create a resilient supply chain. And the wider experience on Europe after the current crisis showcase its role as well as efficacy in many other subtypes of patients, be it from ARDS to just common sedation in our business as usual cases in ICU. There is a potential effect in reducing time to awakening and extubating compared to our traditional kinds of IV sedatives such as VDES and propofol. And there's also a potential effect in reducing incidences of delirium, allowing patients to discharge earlier and reducing the length of stay in hospital as well as ICU. There are also specific class effects of inhalational agents in reducing inflammation, inducing bronchodilation, as well as reducing the amount of peripheral pulmonary vascular resistance in certain subsets of patients. The downside of using the Anaconda system is that it's not widely used as a primary form of sedation in ICUs. Most guidelines all over the world actually do not have much guidance and as well as use of sedation in ICU. If you look at our closest neighbor in Australia, you look through all the CICM teaching and SRA guidelines, they are hardly mentioned in any of this setting. And of course, if you talk about how we go about seeking experience within our neighboring countries in Asia, almost no one has used this before in the ICU setting. It requires some new equipment to monitor anesthetic gas in ICU, which is not commonly done. Okay, and also there's a concern about environmental contamination with regards to greenhouse effect, as well as the management of a new kind of biochemical waste in ICU, which is highly corrosive and not very readily handled by our own ICU staff. The titration of anesthetics at this point of time is also highly dependent on multiple case factors, be it the dick space within a circuit itself, the kind of patients that we have, the physiological issues, the unique ventilations that these patients have, on top of the usual administered dose that we have. And of course, we don't really have the kind of dial on and off agent devices like we use in anesthetic machines. So those are concerns that we all have to address. And these are things that we have to look through and have gained some experience. And Dr. Kerstin shared some of our experience while we embark on this journey. Then also the worry about hemodynamic instability, because we know in OR, when we start a patient on gases, sometimes the BP crashes. It's not something that's not seen before, even in propofol use. Just that it's something that we have to navigate through as we gain experience in using this. And then there are those considerations of who should we use on and who should we not use on. How about patients that are neurologically injured with damaged autoregulation? Is it safe for them to use or not? Because classical teaching in the anesthetic world is that we shouldn't use inhaled agents for such patients. And those are the issues that we all have to face. And then we have to go through the risk of malignant hyperthermia, as well as the cost-benefit analysis. How do we then set up for the trial Anaconda system within our hospital? We explored the 4S, a crisis management system that was taught in many settings. We look at the space, we look at the consideration, we look at the literature, review on environmental contamination and the safety for our staff, because we do not have active gas scavenging in most of our ICUs. We look at our staff, we need to train them up, we need to improve their knowledge, we need to teach them how to titrate this new device. Of course, there are huge resistance in just like any countries or any setting in using new stuff, because they are not used to it, they are not sure what to expect. And then we need to make sure we acquire all the equipments that is needed to have a safe initiation of this trial or this new sedation device. We need to make sure we have a gas analyzer module. We need to make sure the data can flow. We have to make sure the ventilators are compatible. To our dismay, we find that some of our ventilators are not truly compatible with the Anaconda system because of the lack of spare parts, which of course our vendors are actively trying to address at this point in time. And then we have to create a system or a workflow to actually know how to use this or how to recruit patients or for safe usage of this new thing until everyone is very certain of how to employ and titrate this. So this is something that is very important, a guideline to teach everyone. Guidelines are there for a reason, mainly as we progress our knowledge. Once we once you reach a certain stage of capability and expertise, a guideline becomes something in the background. But before we reach that, we need to make sure we have all these things set up. And of course, we then have to talk about quality audit as we do all this going forward, so that we can justify how we can then buy the stuff and use it. Our initial guidelines were very simple. We wanted some patient that has stable hemodynamics, that has an expected sedation duration of more than 24 hours, so that we can maximize our experience on that. And we are only targeting patients whose sedation scores are relatively low, looking for anxiolysis and calming this patient. So once selected, this patient will be inducted on this device at a set rate of about 5 mL per hour initially, and then titrated according to the RAS scores with all the setting, and then we teach them how to win, and from there, we go on from there. We got some of our patients on this thing, and we realized these guidelines was too simplistic, and we revised it. And we came out with a new one, not too long ago in April, as we gain more experience sedating the sicker ones, and our eligible range widens significantly. Our target sedation also increased along the way, and our subtype of patient now includes severe asthmatics as well as COPD and ARDS patients. So there is an evolution in how we use this, and we are here to share how we have engaged our staff in using this. We have the standardized orders and charting, okay, so that we don't have medical legal issues. And from then on, it was relatively smooth sailing on how we go ahead. I'll show you some guides. I think you guys saw the video at the start of the webinar, which was very useful in teaching you how to set up. This is a pictorial guide of how it will look like with just the anaconda system, okay, as well as that of a gas sensor at this point in time. This is the water trap. This is the anaconda system. This is the gas sampling line, okay, and this is the gas. This is the injector port for all our sevoflurane. So this is what it looks like when we start doing all the connections up. This is what it looks like before we connect to the patient, when everything is connected to the test lung and to the Y-shaped connector. And this is what it looks like dangling at the side of a patient. So the setup itself is not difficult. It's actually quite simple. It's much like using the typical HME filter with just an additional connection to a syringe pump. The problem will be that we have to make sure that our syringe pump is not used for other purposes, and this medication is not actually compatible with any IV lines. Thankfully, the ports that comes with the syringe pumps or comes with the syringe itself that supply anacondas are totally incompatible with any IV connections or luer locks. That is a safety feature that we greatly appreciate. So we went through all the device teaching of how to draw the fluids, how to set up all the fluid soak to minimize contamination in different ventilator. This is our Dragger machine, and this is our PB2 980 machine with all the setup and standardizing documentation of when the string changes and how to dispose of it at the point of time. Of note, we noted that the duration of use for the anaconda as recommended by our manufacturer is about 24 hours, as well as the carbon filter can hold about 150 mL of sevoflurane, which is about 3 syringes worth of sevoflurane at the point of time. We don't use isoflurane much in Singapore at this point in time. In fact, we will have a problem looking for that, and that's why you're using sevoflurane. Looking at the tubings, there are actually no mention of when to change it, and thus we have to figure this out along the way, but we realize that most of our sampling lines can last a long time. There's no issues with condensation in such a patient. And if the patient is for nebulizer, we followed the standard guidelines on how to disconnect it, and we realized that there is no issue for these patients on sevoflurane inhalation or anything like that. Okay, so perhaps let's move on to what our patient experience is truly like. Our target populations was patients who were relatively well, who only needed light to moderate sedations. That's mainly, and the hemodynamics. Our main target group of anesthetists or intensivists in our ICU were all anesthetists. We all have good experience in utilizing inhalationers for sedation, and thus the baseline knowledge was never issues. Likely populations that we targeted were airway patients, and our first patient was a patient with airway issue and who was hemodynamically stable. Setup was very easy from our nursing point of view. Patient was relatively deeply sedated despite our intention to lightly sedate the patient with some BP drop at the start. And so we have to cut down our induction dose from 5 mils to about 2-3 mils at the start. And then as we try to do all these things, we realized that a lot of our management plans was compounded by the fact that we still use IV fentanyl, and a lot of our patients are not breathing well spontaneously when we combine use of sevoflurane and fentanyl at the same point in time. So this actually mirrors what Dr. Kerstin has mentioned. The use of opioids for a lot of these patients while they are on inhalationers are a lot lower, simply because they no longer need it. Not that they do not need painkillers, but they do not need opioids as an adjunct to tolerate the tube and to sedate them. And that's what we feel. Subsequent experience were less challenging. Okay, we were having difficulties to get buy-in from other intensivists because it's a new thing. But as we go on, we realized that we are getting better and better at it. And our Thai counterparts were also starting to pick up on this. But their selection criteria were a lot more garang than us. They like to do it on the major trauma and ECMO patients. Our second patient was someone with epiglottitis, and the experience was pretty much similar. There were no issues. And our third patient was probably the one that we had to deal with for the longest. This patient was quite sick with neck fash, and it was hard to sedate at the point of time with the need for very high doses of IV anesthetics and IV sedation and IV painkillers. It was quite challenging keeping him calm. The moment we start the inhalationer, the patient went flat and went really calm. It was easy to wake him up when we don't need him to be sedated to participate in hemo in physiotherapy, and that was the goal, as what was mentioned by our Indonesian counterpart earlier today. We want our patients to be engaged in physiotherapy. We want them to take part and take charge of their own health, even while they are sick and being cared for in ICU. And we also managed to stretch the use of reflector to more than 2 days without any perceived issues to resistance or efficacy. These were just testing grounds for us at the point of time. So as we go on, we got more and more used to it, more and more intensivists buy-in. We started using it in sicker patients, and there were severe asthmatics that benefited from the use of it. And over time, more of our staff has been using this anaconda system over the last 1 year. The use and the frequency of deployment of anaconda system has been increasing over the last few months, and the duration of use has also been picking up. The learning point thus far, as if I may summarize, is that setup was very easy. Disposal will need to be dealt with based on the hospital's policy in dealing with biochemical waste. It was initially difficult to titrate patient to be lightly sedated, but we realized the whole role of a sevoflurane may not necessarily be aimed at titrating to a light sedation or anxiolysis. The advantage of the sevoflurane anaconda system is that we can keep them very deep, and yet we can wake up very fast with a very clear-minded kind of head in less than 5 to 10 minutes. And we can then allow them to participate in physiotherapy. And when they can no longer tolerate it and become agitated, we just turn it back up and they go back to sleep. And yet they are breathing spontaneously at the same point of time. So there is a lower risk of wasting of muscles and everything like that. And on top of that, because of the reduction of need for opioids in such patients to improve tube tolerance, the amount of complications related to opioids has been reduced over the time. There's less gut failure, less ileus along the way. And that is the beautiful thing about using sevoflurane and anaconda in the ICU thus far. Of note, we do have to say that it does not do away with the need of opioids in a lot of our patients, but in our ICU, we actually employ a lot of regional anesthesia in a lot of our patients that comes to the ICU with injuries. If I may, example would be someone with AAA. Actually, I have a patient now with AAA that has ruptured. He's currently in my ICU of sedation and of extubated. He's currently on bilateral ESP catheters to manage the pain. And then I have someone with a diaphragmatic hernia coming for obstruction. He was still intubated and was elderly. We put in 2 catheters, the rectal sheath, to help manage the pain. And with sedation that is light, we can get them to be quite calm and mobilize them quite easily, as well as enhance gut motility and stuff like that. The average consumption in our setting is about 1 string of sevoflurane per day, which is about 50 mils kind of thing, based on how susceptible they are. Cost can be an issue, of course, at the start. But I believe with time and with more usage, perhaps we can bring the cost down all over Asia, not just in Singapore. And with that, I will end my talk and allow our host to clarify and allow the Q&A continue. Thank you so much.
Thank you very much, Dr. Luis, for the sharing your experience in using inhalation sedation in ICU. Okay, now we are continuing to the next session. We are going to enter the question and answer session. Okay, let me deliver the rest in bahasa ya. Oke, selanjutnya kita akan lanjutkan dengan tanya jawab. Kita akan menghadirkan dua panelis yang sangat tersohor ya. Yang pertama adalah guru saya, dua-duanya guru saya. Yang pertama adalah Dr. Yohanes George Sp.An KIC. Beliau sudah tidak perlu diperkenalkan lagi ya. Beliau sudah adalah guru kita semua. Nah, yang kedua adalah Dr. Rudyanto Sedono, Sp.An KIC. Beliau juga adalah guru dan kepala sekolah kami di FKUI ya, di RSCM. Nah, saat ini kita akan berdiskusi dan kita mau dengar juga bagaimana pendapat dari kedua praktisi ICU yang sudah sangat berpengalaman di bidangnya. Okay, I would like to ask Dr. George and Dr. Rudyanto. I'll ask your comment first about this new technique of sedation in ICU. What do you think about? What's your comment about this, Dr. George?
Rudi dulu deh.
Dr. Rudi first. Oke, Dr. Rudi silahkan. Dr. Rudi deh, Dr. Rudi kan belum muncul. Tadi Dr. George sudah ada kangen. Ayo dok.
Yeah. So. First of all, I want to thank you to the PERDATIN and JCCA that inviting me to this webinar. So this is a very interesting topic, very interesting speaker. Dr. Louis, thank you. Dr. Kerstin, thank you for your lecture about the new paradigm sedations in the ICU. Now, in Indonesian, I think these devices or the system not yet used in Indonesians, and there is a few comments, a few discussions that more discussed with you, Dr. Kerstin and Dr. Louis. It's about the devices. So it's mean that we move the system in the OR to the ICU. And then how about to set up about the devices, about the scavenging, about a lot of devices that use in the OR to the ICU. So how about the air pollutions, something like this? Is there any technique or any system that can diminish the air pollutions of the inhalation agents? And so, is there any comment from Dr. Kerstin or Dr. Louis? It is safe to use for a long time. And how about the combinations of another sedations or analgesic agents? We know that to achieve our analgesic and sedations in the ICU, we use a multimodal combinations of the sedations and analgesics. So do you have any comment or do you have any experience in how about this sedations technique combined with another sedations, including IV sedations? And how about the patients with especially shock septic and especially with shock, and we need to give sedations? How about the hemodynamic in these patients? I have your opinion, something. So maybe the first discussions, I have communications, these discussions with you. Thank you, Dr. Vera.
Okay, thank you, Dr. Rudyanto. Okay, question maybe addressed to Dr. Kerstin and Dr. Louis, but I please, Dr. Kerstin, Dr. Rudy is asking about the safety for the environment, the air pollution of the inhaled sedation, inhaled agent. And then the second one is how to use it combined with the other sedative drugs. Please, Dr. Kerstin.
Okay, as to the environmental pollution, we have measured 15 years ago because we didn't know where the pollution is going if we don't have an active scavenging like we have in the OR. So we were measuring and we collecting some data. So what you can see from the literature, there are several publications over the last 15 years measuring a volatile anesthetic concentration in the patient room during anaconda. And for different countries, we have different limits of ppm, parts per million. Usually it was said like 2 ppm to be the margin for healthcare workers in the OR. So this is something that was set in Germany as well. It was adopted, and we measured around 0.1 to 0.5. And if you have a look at all the other publications, you see that usually the main concentration that you can measure it is very, very low. But it has something to do with handling. If you open the circuit just in front of the anaconda, of course, then in the next inspiration, everything is coming to the healthcare worker. So you have to learn about this and you have to be sure how to disconnect. And then we always use to avoid any environmental pollution, passive scavenging. There are different exhausts from different ventilators. If it's Draeger or Mindray or a Hamilton or something, you just hook it with a tube and then you use a passive scavenging system. And the future will be to recycle the gas inside these carbon fibers. And we know that the concentration is very, very low, but you have to learn how to use the technique and avoid these small peaks you're going to have when you disconnect. So in general, there is no harm for healthcare workers to use anaconda in the ICU and work at the patient place. And to the second question for the polypharmacy, meaning that you use other sedatives together with volatile anesthetics. I have to admit, when we use isoflurane, we usually don't use, at the first moment, don't use any other agents. It's sulfentanyl and isoflurane. We start like this. And if then in the next, I'd say 1-2 weeks, and we use isoflurane, we feel that we want to have a more lighter sedation and wean the patient. We sometimes see this tachycardia and this a little bit of agitation where the patient, they don't know what was happening the last 2 weeks. So they have to get adopted within hours to breathe at a ventilator, to judge where they are, what happened to them. Then we adjust clonidine. We use a lot of clonidine for weaning, but usually we don't use no propofol, no ketamine, no midazolam when isoflurane sedation is running. It was only in some of the very obese patients in prone positioning during COVID-19, they needed a lot of sedatives where we said, okay, now is the moment. We want to avoid muscle relaxants. We give a little bit of ketamine, but usually you don't have to use any other agent together with isoflurane or sevoflurane sedation.
Okay. Thank you.
Thank you.
Thank you, Dr. Kerstin.
Thank you, Dr. Kerstin. So we use it single inhaled sedation, single drugs. So we avoid the IV. By using this, we are trying to avoid the IV sedation.
Once again, how about in unstable hemodynamic, Dr. Kerstin? Do you have any experience in patients?
Yeah, I use it in all septic patients and all shock patients. I mean, it's a little bit different when we talk about cardiac shock, because usually the cardiac output is low, so there is a lower concentration and intake in the patient. And but if you use propofol, for example, you have most of the time this huge hypotension in this patient. So in septic shock, we don't really see a difference. We use noradrenaline, norepinephrine. We use it what the patient needs, but we don't see really this, that it's producing more instability with isoflurane than using propofol. I mean, the propofol is a substance that produces a lot of hypotension. So it's not really a difference. And there are several studies where you can see it. And in this last one, the CareMart study, you can see it, the use of catecholamines in COVID-19. There was no difference in hemodynamic instability. So most of the time, we really don't see extra hemodynamic instability in septic shock. No.
Okay. Okay.
Thank you. Dr. Luis?
Interesting, Dr. Kerstin. Thank you.
Thank you for the questions.
Okay. Dr. Luis, do you have any experience in, you mentioned about the stability in hemodynamic when you choose with the inhalation sedation, but do you have any experience in septic shock patients?
We haven't really used it in any of our severe septic shock patients at this point in time. Main rationale is because we are just starting up. The most seriously ill ones are our severe status asthmaticus that we have, and of course some of our neck fash of the neck. The BP wise is actually not too bad. If you run a sevoflurane or end-tidal 0.5 to 0.8, you usually keep them quite calm. In fact, when you have end-tidal 0.6, most of them are asleep. So the initial induction phase, when we started at very high at 5 mL per hour, maybe that's why the blood pressure kind of crashed at the start. But they could also just be underfilled. But the subsequent patients, we never had much issues. And to be frank, a lot of our patients who we sedated are very agitated. So sometimes after we sedate, the sympathetic response dropped, and thus the blood pressure goes back to normal. So a lot of them are just chronically sick. I can't tell whether the sedation itself caused all these things, but it's expected. Any kind of sedation, when you take away the anxiolysis, you take away the sympathetic surge, the blood pressure will plunge. So far, I do not think it's worse than before, but it's about learning how to titrate it expectantly. Because if you compare running a propofol of 30-50 milligrams per hour, compare the sevoflurane of MAC of 0.3, the effect is actually different. 30 to 50 milligrams of propofol is probably minimal, it's almost nothing. But running a sevo of 0.3 MAC is almost a GA or a MAC asleep dose. So you're actually looking at a deep sedation, and thus effect will be different. So we just have to be very aware that the amount of sedation that we are looking at is actually different. We may not actually achieve the anxiolysis kind of thing. It's more like the on-off effect. And thus, when you're looking at the on-off effect, obviously the hemodynamic stabilities may change a bit along the way. But in patients who have septic shock and encephalopathy, actually they don't need too much. They are quite flat anyway. You just need a bit to tolerate the tube. So you actually don't need very deep sevo sedation, maybe a sevo 0.1, 0.2. Just keep them calm and tube tolerant. And I believe with that, the effect of hemodynamic instability from the point of view will be minimal, because the same experience applied when you're running propofol of 20 to 30, fentanyl of 10, 20 mics. There's not much effect on the BP, right? So that's how I see it. And the extrapolation will be similar. That's how I view it.
Okay, thank you. Okay, next, Dr. Josh, ada any comment or?
I'm interested to the study performed in Germany, especially but I maybe I didn't hear what Kerstin said about did you explain in study of Bellegarde about the retrospective study about the survival with isoflurane and propofol midazolam. Did you explain the possibility cause why the isoflurane better survival and compared to propofol midazolam. That's the first. And second question about the ERDS. Unfortunately, the study was only one in non-COVID and one in COVID patient. And this only the age parameter, this study of the ERDS, because it's very interesting me because you know the volatile was excrete and work in the alveoli. So why in the such of bad lung it be better than the intravenous? It's interesting to me, and the study of the Joe Biden and in the COVID 2021, the Acidin Kermat. Yes. Can you explain the mechanism why the volatile is better in ERDS patient?
First of all, we see something but they haven't really proven, I mean, to be better in terms of every inflammatory markers. We see something, and okay, let me start this way. From the ARDS and the COVID usage in COVID, we have learned that it seems that volatile anesthetics, not in the last 5 years, even for the last 10, 15 years, can modulate inflammation. We know that volatile anesthetics have a special potency to have anti-inflammatory effects that has been seen in rats, in animal models, and in vitro studies. The thing is how we can prove it in the patients, and most of these studies are from ethical committee and from university hospital, restricted to 2 or 4 days of investigation. So we only have this small period where we can investigate and see markers, inflammatory markers that are lower, and oxygenation that is better. But what has to be proven for the future are randomized controlled trials to see these really septic patients suffering from pneumonia, ARDS, and then the outcome of these patients. Because you were talking about the Bellegarde study, where we have a difference in mortality, survival. So the problem is this is retrospective, and there might always be bias. Although we see 20%, it's promising that volatile anesthetic can change the outcome and inflammation in these patients. But at the moment, we don't have really the study to say, now this is the proof, but we know from all animal and in vitro study in these first pilot studies that it seems that volatile anesthetics are involved in this inflammation, and that perhaps they're going to have less pneumonia, like nosocomial pneumonia, but it hasn't been proven. This is the only hint we have at the moment. Luis?
Yeah, I totally agree with Kerstin. I mean, we have to interpret the studies at this point in time with very, very careful interpretation. Most of them are extremely small scale. As I complained to you before, I couldn't find much data to prove to anyone. If anything, they are all small scale studies, single institutions. They're at most an association of some form. And we know how such studies are such great pitfalls along the way. We have so much hope in so many agents along the way, and none of them has actually come true. Whatever has come true has always been far in the field. So we have to be very, very careful at how we interpret this. The signal is there, but just like anything, until the signal is proven to be a causative effect, we can't show much things. And even then, the causative effect must be translatable to all settings. And must be generalizable in everything. So it's not something that is easily looked at this point in time. And as one of the Dr. Susilo has mentioned, it has not penetrated a lot of markets along the way. And despite being in use for more than 10, 15 years or even 20 years, the amount of information on market is as good as gelafandin. What do we know about gelafandin after 20, 30 years of being used? No one really know what we are doing with gelafandin in the system. And that is a fact because we haven't found much use in it. It's still a very specific kind of intervention, very peculiar to certain countries. And we are so glad that Kerstin and our German friends are sharing this knowledge. And at least from my point of view, at least Singapore, we are now engaging in such things. Hopefully, the increase in penetrance of use can provide a chance for us to investigate this further in a multi-center trial. And then we can then think about once and for all whether there's truly benefit in mortality and in morbidity or even in inflammation. But beyond then, let's stick to how we can use it as sedation as an alternative agent. The fact that it is a good alternative fulfills everything. None of our agents at this point in time improve mortality, right? The fact is we just want them to wake up fast and correct thing. One point that we have to be very sure of is that none of the drugs we use at this point in time target the underlying physiology or pathophysiology. As long as the underlying pathophysiology is not addressed, I doubt there will be significant mortality change at this point in time from anything. If anything, you'll probably be incidental. If incidental, we can't even tell you whether it's chance or luck. But most importantly is that it doesn't cause harm. When it doesn't cause harm and it has a role and a certain benefit, I think that's the most important thing that we are doing now. Cause no harm, provide relief, and we move forward from there. And that is how I would say.
Yeah.
Yes.
Thank you.
Yeah, I know that. That's my second question. Thank you for Dr. Luis and Dr. Kerstin. And the second question is, you know, all the anesthesiologists know well that if we, for example, we doing anesthesia and maybe after 1 or 2 hours the hemodynamic become unstable, we immediately change and we shut off the gas and start on the N2O and oxygen and using, for example, ketamine. So that's still my question. If we perform it in critical ill, but Dr. Kerstin already explained how safe, and Dr. Luis said that we use it, Dr. Luis used for the moderate or stable hemodynamic. So maybe it is important for our colleagues in this audience, for most of them is anesthesiologists, that the most important that we adding one more alternative for sedation, not for all the patient in ICU, but we have one alternative which we can use, for example, for post-operatively stable patient, and we have to fast wind. Maybe it becomes a great thing if we have many kind of sedation rather than only a few. As we know that Indonesia mostly use midazolam, and because of the price and combined with morphine. So sometimes, you know, midazolam, if we give 15 milligrams, and after 10 minutes, the patient can wake up from the bed and standing bed and uncertain. But we know exactly what the volatile, for example, CFO, we know well, and it could be induce deep sedation. But maybe for the certain people and population, so it's very individual. I think maybe our colleagues can have a new strategy for sedation. That's my comment, Dr. Vera. Thank you for the explanation.
Thank you, Dr. George.
one comment on that. I mean, you have to think that it's for the first time an alternative, because in Germany, for example, midazolam is so out because we know that it triggers delirium, and we have a lot of agitated patients. They have to reorientate within days and weeks. So for us, it gives us a new opportunity that we know very well how the wake up is. It's not really modulating a lot of the cognitive function, and we think that we have just one agent. We don't mix it as a polypharmacy, because then you don't know if this symptom is coming from ketamine, this symptom is coming from clonidine, this symptom is coming from midazolam, and you mix it. We often just try to use one drug to be sure that it works. And for hemodynamic instability, what are we doing on the OR? Usually if somebody is in a hemodynamic unstable, we just tap down the vaporizer, because we don't use that much not to have unstable or bad hemodynamics. So you can do that as well, not to use high MAC value, but just 0.3. Okay, just to have like a MAC awake and just taper it down and use it a little bit. But the reason for us in Europe is not, the reasoning is not that we use 50 milligram of midazolam. If I would use 50 milligram, I mean, my head of the department, he's going to not beat me, but he will be very angry, because this is something that is no longer in fashion, and we know that it takes quite a long time to recover, especially for old patients. So this is not the strategy we follow.
Different in Indonesia. So we have midazolam as a protocol because it's cheaper. But I have one question for you about I already hear you said many times about clonidine. In Indonesia, I think we already know clonidine in ICU, because the side effect is bad rather than dexmedetomidine. We use sometimes dexmedetomidine rather than clonidine. Why in Germany still use clonidine for ICU sedation?
Price. It used to be at the beginning when they started dexmedetomidine. It was not launched in Germany in the very beginning. Coming from the US, it was very expensive, very, very expensive. And you usually have to trade it by tables. You have to have a tool to calculate, and we saw a lot of bradycardias. With clonidine, it is very cheap. We are very much used to it the last, 30 years. So this is our drug of choice for weaning and delirium, agitation. We use a lot. We don't inject it directly as a bolus. It's not very common. Sometimes we do, but usually we have a syringe pump running when we want to wean the patient. So it was, I think in the beginning it was the price. Now the price has is just 1/3 from the beginning. People use more dexmedetomidine, but it's not something that is so much in fashion in Germany.
So you use clonidine as a single analgesia, or you use for sedation? No. Combined with sedation?
For sedation, not as an analgesic. It's more for sedation, and we even give it to patients that are not intubated. If they are on delirium, they get a syringe pump running to avoid this sympathetic tonus, and to a little bit smooth down, sedate them, and try to reverse. They have this reverse day-night understanding, and just during the night to smooth down a little bit the symptoms and make them sleep. Yes, not as energetic.
Thank you. This for info for Dr. Rudy. Rudy, gimana Rud? Mau midazolam apa clonidine, Rud?
Really? Good.
Okay.
Thank you, Kerstin. Maybe Dr. Louis I have about that.
I agree with Kerstin. I mean, clonidine does have its role. I mean, we don't use it that often, but we find that it's very useful to to deal with patient with delirium. Dexmed may not always work for delirious patient. It is keener, but the effect may not always be sustained. We do find that some of these patients get some form of tachyphylaxis to Presidex after a long term. Don't know whether it's really real or we are just hallucinating ourselves. We're getting delirious, looking at them getting delirious. But the clonidine sometimes calm them down a lot better. 25 mics, 50 mics, lasts for about a good 1-2 hours, especially when you try to wean the patient down. When they are tachycardia agitated on Presidex 7.7.1, 1.5, by then there's nothing to control them. You give a small bolus of clonidine, it works wonders. Calms them down, prevent them from jumping the bed, give us a bit of respite, and we continue again.
Guys,
Okay.
thank you.
Thank you, Dr. Luis and Dr. Kerstin. Untuk Dr. Irfan, tadi pertanyaannya sudah terjawab ya, Dr. Irfan ya, tentang bagaimana inhalasi sevofluran itu bisa meningkatkan oksigenasi. Jadi saturasi pada pasien ARDS itu membaik setelah pemberian 1 jam menggunakan inhalasi sedasi ya. Dr. Irfan bisa muncul nggak di sini? Jadi efek antiinflamasi, jadi volatile anesthetic dia modulate immune response. Jadi dia ada efek anti-inflammatory sehingga mungkin itu yang memperbaiki selain tentu mungkin efek bronchodilatornya ya. Oke, saya mau masuk ke komentar Dr. Susilo. Dr. Susilo is our seniors, our teachers ya in medical school. He said that anaconda was promoted and introduced in Indonesia more than 10 years ago. But it's just fade away and no one use it practically in the ICU. So do you have any comment or you have any suggestion so we can continue to implement the inhalation sedation in ICU, not only sharing knowledge and sharing experience, but it's just stop there. Maybe Dr. Susilo, can you turn on your camera and speaker? So we want to hear from you. Dr. Susilo, are you still there? Okay, maybe. Okay, maybe you can share more how to have a gut to start this.
I don't think it needs a lot of guts to start. I think as long as we are all in sync, I think a lot of our panelists here are all interested in it.
Yeah.
All we need is to have a consensus that let's give it a try. Let's share the positive experience. And when the word gets out that it's safe, can be done safely, more and more people will pick it up. I started this way back in February 2021. But at the point of time, everyone asked, it was here before. We never had a nice, never had a way to use it. Then we approached the other hospitals, especially our COVID hospital. We approached Tan Tock Seng, and they asked us a simple question. We are so scared of environmental contamination. Our environmental lobbyists has literally rate war the device. And at the end of the day, what happened is that as we use it, we show our juniors how it's being used. The good word of it came about. It spread to Singapore General Hospital. They are on trial now and they're using it. They I think used 3 or 4 cases so far. And then our medical colleagues within the hospital used it. And now our colleagues in the other hospitals are inquiring about it. I guess it's about sharing it, telling the non-adverse experience, telling how we troubleshoot all the stuff, and then laying the groundwork for this device to penetrate further. It will never be as good as Propofol at the end of the day, because as long as the data is lacking, it will never overcome the same stuff. I mean, you can never replace what is norm unless it becomes norm itself. But the fact is that I think it is like what Dr. Yohanes has, Dr. George has mentioned, an alternative. An alternative when we run out of other things. What happens when the next pandemic comes about? What happens when we don't have NIDAS? What happens when we don't have Propofol? Should we not have another way of doing things? We are all doctors. We need to look for alternative, and we have to try it out to know that we are skilled and able to do it when we are forced to do something. Why not then embark on a journey to improve our ability in all areas? We don't have to be the master of everything. Maybe a jack of all trades would be good. And then we try how we can do this in patients. I'm sure there are subset of patients that will benefit from this. We just don't know yet. But unless more people try, we will never get there. But most importantly, like I mentioned before, no harm is done. It's safe. So why not when it's safe? Yeah.
Agree.
Okay, it's no harm to try it, yeah. Okay, I see somebody raise hand, Dr.
Silo udah ada.
Dr. Susilo. No, Dr. Susana Sitaresmi.
Oh.
She raised hand. Dr. Susana, please, silakan dok. Dr. Susana ada di sini. Silakan dok.
Lagi bius ya kayaknya.
Oke. Dr. Susilo sudah bersama kami kah? Dr. Susilo. Ya, dok, silakan beri komentar. Silakan dok, gimana? Kenapa sih kita tidak bisa running, kalau bisa jalan? Padahal 10 tahun saya pikir belum pernah. Kita pikir baru ternyata enggak.
For us, that we know actually this equipment is already exist more than 10 years ago, but nobody care about this. So I challenge my colleagues, intensivists in Indonesia, why don't we try? Don't be worried too much to try. Maybe 1 or 2 or 3 ICUs try this with the good protocol. Maybe ask for the 2 speakers how to make it better for our patient. Actually, I'm not an intensivist, so I challenge you all to do this. Thank you.
10 tahun setelah JCCA mulai bangun, dok.
Did it maybe more than 10 years ago in Indonesia. We do a lunch symposium. We also do a sitting trial in RSCM ICU, but seems no reaction from your side, not from my side.
Thank you, Dr. Susilo. Maybe ada teman-teman dari RSCM kah? Dr. Rudyanto, how your comment about this? Katanya sudah pernah di trial di RSCM, kenapa nggak jalan ya dok?
Yeah, if I don't forget, we trial Anaconda in our ICU, maybe 10 years ago when Dr. Susilo head of department and I am the head of the ICU, and but it is only for 1 or 2 patients for exercise, and after that I don't know why.
Why? What was the obstacle, dok? Masalahnya apa, dok?
Now the obstacle, the obstacle one. This is the new technique. And it's like new. Dr. Louis, it should be explained to the nurses. It should be training to the nurses to good, because if we get some prescriptions for the sedations with the inhalations, and in 24 hours, that will look after the patients is the nurses. So that is the problem in Indonesians. We should, because in Indonesians, ICU nurses, it is different between the OR nurses, that anesthetic nurses, and so we should give any explanation, any training. That is one of the obstacles in Indonesians, and it is not easy in Indonesians to challenge that, because they 24 hours they should take care of the patients, not only take care of the devices. This is the new, and then they should like Dr. Louis, they should change this and then put this in this. Is there any obstacle? Is there any problem? We should in other conditions, the nurses take care of the patients. A lot of problem in the patients and a lot of devices in the patients. So that is one of the one obstacle. And then after that, when we try to take care of the ventilations, and then from the technicians, the medical technicians in the Cipta Mangunkusumo, they ask, so what is the effect of fluor from the volatile anesthetic agents to devices, to the like oxygenator, like from the devices, and then after that, is this corrosive or not? So at that time, I cannot explain, and I cannot give any answer to the medical technicians, and it should be get any experience. So if the devices, for example, we give sedations, and then after what many hours, maybe 1,000 hours ventilations, how about the conditions of the ventilations? So something like that.
I think with better knowledge now, I think we are happy to share.
Yeah, absolutely.
We embarked the same journey. I mean, what you have said so far is exactly what my nurses told me. But the fact is that we have experience now. We have tried everything. All is good. And the moment they realize that it's actually quite easy to titrate, you just turn on and off the syringe pump, titrate according to the patient's needs. And that's it. It's no different from Propofol. Yeah, so the change is not more difficult than drawing from a Propofol syringe too. And disposals are not more difficult. All it needs is confidence. So having a good protocol at the start, and a good feedback system from the nurses, and an enabling culture will be the good way to go. Just like how we face it. I mean, we had 2 different ICUs, and the experience are vastly different. As long as we start on the good thing, we lay the groundwork, as what I mentioned, through the 4S. Usually it starts with a hiccup. But if you jump in without a nice setup, then you are at higher risk of failing. And that's how I see it. I do for apologize, I do have to run somewhere. So in the short while, I have to log off accidentally.
Yeah.
Thank you, Dr. Luis.
Thank
you for your time and your great sharing. Okay, goodbye. See you soon. Okay. I think the time is running out. Is there any questions?
Yeah.
Okay, Dr. Henry, please. You have maybe 5 minutes more. Okay.
Just short question, maybe clarification question. Is there any like a particular condition, I mean lung condition, to use this medicine? Because we know that the side organ is the brain. What if the patient with the lung cancer, or maybe have like hyaluronate, I mean, sorry, it's like edema, or maybe with the disease in the lung? That is the one. And the second one is there any like effect tachyphylaxis for this medicine? I mean, is it the same effect if we use maybe 6 hours, or after that, and maybe after the 12 hours, the same effect? That's all. Thank you.
Thank you, Dr. Henry. Please, Dr. Kerstin.
Yes, as far as I got the question. So first of all, I replied to the last question. There's no tachyphylaxia that you're going to see sometimes, but this is part of volatile anesthetics. You see a tachycardia at the end that's stopping, but not in all patients, and sometimes hypotension, but something we experience in the OR as well. And the first questions, I didn't really get it. You meant that if we have edema in the lung, if we have acute lung injury, if there is any difference in the uptake of the volatile anesthetic, is that what he asked for?
Yeah,
Very
asking
exactly.
about, yeah.
Okay,
about,
so usually there's no compromise. No compromise. The uptake of volatile anesthetics is very, very easy. It goes very quickly, and it's not dependent on the function of the lung or edema. What we sometimes see is if you have an interstitial problem, it might be edema, but other reasons, we have a CO2 problem, CO2 rising, but this is something we see when using propofol and midazolam as well. But affecting the volatile anesthetic, there's usually no compromise. You can just use it. You just have to think that if you want to get secretions out, and you'll have a lot of secretions, you have to use a closed suctioning system, because you always, when you're suctioning, you suction out a little bit of volatile anesthetic. So from the practical side, we often give a little bolus before we do suctioning to have a little higher concentration, then suction, let the patient cough, get the secretions out, and then do a normal inhaled sedation. Did that cover your question? I hope so.
Okay. Dr. Kerstin, for the the longest duration you use inhaled sedation, how days, how long?
How many days?
How
I
many?
usually use it like I have just I mean I use it as long as I need it. Isoflurane, not sevoflurane, isoflurane. And I just was reminding my patient from COVID-19. So I just had one patient. He was 38 days on isoflurane. He was tracheotomized, as a difficult weaning, but when we woke him up, he was alert after 1 day without delirium. There are some case reports, and if you have a look, for example, at the Grasselli study, up to 38 days, we have one case, they reported about a special neurological epilepsy patient of 3 months, but that is, I mean, that is not common. This is individual use in patients. So I use it as long as I need it. And I'd say in critically ill septic shock, it's usually 2-3 weeks. Yeah.
Okay, 2 to 3 weeks. Okay, Dr. Henry, you are satisfied with the answers?
Yes,
Dr.
of
Henry?
course.
Okay. Okay, thank you. Okay. Now, Dr. Vanessa is asking about, do you have any bad experience, negative experience while using this technique for sedation?
Bad experience.
Yes, about experience.
I'd say the bad experience is mostly what you were discussing, not using it, and what can happen. I mean, changes in the ICU is not that you make changes within weeks. Changes in the ICU, my experience is takes years, and at the moment you turn back or go on holidays, you come back and you feel like, well, this is something I wanted to change for the last 2 years, and it's happened that everything was vice versa when I came back. So what happens sometimes if healthcare professionals are not used to the technique, they come in new and they feel uncomfortable, then sometimes they take out the anaconda during the night, because we have some nurses, they only work on night, they don't have a good training. So this is something that can happen from I'd say from education. But bad experience sometimes, if you have low tidal volumes and you don't really get rid of the CO2, then we have some patients prone positioning, ARDS and low VT under 350. Then we usually have hypocapnia, and we can get rid of it. Either you put it then in the inspiratory limb, the anaconda system, or you just have to change sometimes for an IV sedation. But that is only in the condition, I mean, we usually, in Germany, I mean, I don't know how it is in Indonesia. I have no experience. I've never been there, but we have a lot of obese patients. So usually 380 ml per tidal volume is already quite low, like 4 ml per kilogram. So usually we don't see it, but this is something that can happen. Hypercapnia because of low tidal volumes. You have dead space. The dead space is the same as an HME filter, but it can happen.
Okay, thank you very much. I think the time is up. Thank you very much, Dr. Kerstin, Dr. Echa, Dr. George, Dr. Rudyanto.
Vera,
Yes.
ya jadi
This
simpulkan dulu ya.
always something. Ya, Dr. George, silakan.
Conclusion for the audience. Jadi bahwa memang butuh keberanian ya.
Ya.
Mungkin yang dikatakan Dr. Susilo tadi 10 tahun lalu, memang butuh lebih banyak lagi intensivist anesthesia origin supaya lebih berani, karena obat ini kan anestesi yang pakai, dia tahu safe-nya, tinggal implementasinya kali harus seperti Dr. Kerstin dan kawan-kawan ya yang berani memulai. Saya rasa itu kuncinya. Jadi kita nambah lagi perbendarahan. Jadi mudah-mudahan dari RSCM Dr. Rudi udah bisa mulai memotivasi sebagai dokter, dan nanti akan diikuti oleh
followers
kita kan followernya akan ikut, siapa tahu ya itu jadi perbendaharaan baru kan, bukannya jadi perubahan standar, enggak, hanya menambahkan suatu tools baru, tidak harus semua pasien pakai itu, tapi at least kita nambah perbendaharaan kan lebih baik. Mungkin bisa ditranslate ke Dr. Kerstin. Sorry Dr. Kerstin, I have to talk in bahasa.
Oke. Terima kasih Dr. Josh sudah membantu saya membuat konklusi. Jadi as a conclusion, now we have there is a new technique, a new alternative option for for delivering sedation in ICU by volatile agents, and especially for the mechanically ventilated patient, And as we have heard, the speaker said that is safe and comfort for the patients. And then to make it available in ICU, we need to learn more, train more, practice more, so we can get used to it and implement it, not just discuss and then that just disappear. So it is and it is safe for the critically ill patient. Maybe that's my conclusion. Thank you very much, Dr. Kerstin. We will really appreciate your time and your great lecture. And Dr. George, Dr. Rudi, terima kasih banyak.
Terima kasih.
Dan juga
Thank you, Dr. Kerstin.
Kerstin, terima kasih banyak.
Terima kasih Dok, terima kasih semuanya untuk partisipasinya.
Terima kasih sehingga mudah-mudahan nanti bisa lebih banyak safari ke ICU yang
Amin.
Bisa semua mencoba sehingga akhirnya nanti kita bikin training buat perawat, buat dokter jaga ICU, sehingga mudah-mudahan ini bisa terjadi.
Seperti sarannya Dr. Susilo ya Dok.
Iya, oke.
Baik Dok, terima kasih banyak semua.
Dr. Vera, terima kasih banyak.
Thank you.
Terima kasih Dr. Jos.
Bye.
Vera.
Terima kasih ya, Anamet.
Saya kembalikan ke
Thank you Dr. Kerstin, thank you Dr. Louis, thank you all. Dr. Haizah, terima kasih banyak.
Sama-sama.
Sehat dan sukses selalu Dok, jadi profesor ya.
Terima kasih ya. MC
sama-sama.
Pramutia, silakan Mbak.
Terima kasih Dr. Vera.
Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Terima kasih Dr. Vera. Terima kasih sudah dipandu sampai akhir. Diskusinya sangat-sangat menarik hari ini dan sangat interaktif. Terima kasih juga untuk para narasumber dan panelis yang sudah bersedia berbagi pengalaman dan penjelasan mengenai tren sedasi ini. Much appreciated for all the speakers and the panelists too. Juga kami ucapkan terima kasih untuk para peserta atas kehadirannya pada webinar hari ini. Semoga apa yang disampaikan akan bermanfaat bagi kita semua. Amin, amin ya rabbal alamin. jika Ibu atau Bapak dokter anestesi ataupun intensivist di sini yang masih memiliki keingintahuan terkait produk ini ataupun terkait inhalasi sedasi, silahkan sampaikan pertanyaannya melalui kontak yang sudah di-share oleh admin kita. Nanti akan kami tampung dan dijawab langsung oleh para pembicara atau para panelis, dan nanti kita akan sebarkan melalui email. Seperti itu. Dan saya mewakili dari tim panitia yang bertugas, mohon maaf jika terdapat kekurangan atau kendala teknis yang terjadi. Selamat sore. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih semuanya.
Dr. Vera, thank you semuanya.
Izin dok, link polling yang mau diisi ada dok?